welcome to the deep dive. Today we're doing a high-speed, high-yield run-through of peripheral nerve material. If you're a resident prepping for your boards, this is really designed to be the ultimate shortcut. We're going to cover anatomy, injury, and repair techniques. We are cutting straight to what you absolutely need to know.
Right. The goal here is to give you that critical foundation to just ace this section of the exam. We're going to focus on clear definitions and, maybe more importantly, draw those crucial lines between concepts that can be confusing. You know, Seddon versus Sunderland, M2 versus M3. Let's just jump right in.
Okay, let's unpack this architecture then, because you don't understand the layers, you can't understand injury severity. So under the microscope, what are the key connective tissue layers a surgeon needs to identify?
So we start with the neuron itself, the cell body, dendrites taking impulses in, and the axon carrying them out. But the nerve's resilience, that really comes from its wrappings. There are four critical layers, going from deep to superficial. The deepest is the endoneurium. It surrounds each individual nerve fiber, each axon.
So if the endoneurium is breached, you've already hit the structural integrity of that single fiber.
Precisely. And then those individual fibers are bundled together into functional groups called fascicles. Those fascicles are then wrapped by the second layer, which is the tough perineurium.
Okay, and if we group those fascicles together to make the whole cable, what's wrapping that?
That's the epineurium. But, we actually divide it into two parts for clarity. You have the intraneural epineurium, which is so important because it contains the blood vessels, the vasa nervum. And then finally, the outer epineurium surrounds that whole group of fascicles to form the peripheral nerve trunk. Knowing this hierarchy is absolutely fundamental. The classification of injury maps directly onto which of these layers is breached.
Right, and that structural resilience depends on speed, and that speed relies on the Schwann cell. So walk us through how Schwann cells and conduction fit into these structures.
Schwann cells are, they're the support system and the speed boosters. In myelinated nerves, they produce that multilaminated myelin sheath. But a key point for the boards, even unmyelinated nerves are not naked. They're still ensheathed by a double basement membrane that comes from Schwann cells.
And in the myelinated nerves, these Schwann cells meet end-to-end at the nodes of Renvier.
Exactly. And this is where that high-speed function comes from. The action potential literally jumps from one node of Renvier to the very next one.
So conduction isn't continuous.
Not at all. It's called saltatory conduction, and that's the mechanism that lets those large myelinated fibers, the ones for rapid movement and sensation, get such incredible conduction velocities.
Okay, so if we're connecting this microanatomy to function, we need to know the official speed limits to understand movement, sensation, pain. We classify nerve fibers by diameter. Let's do a quick run-through of the Group A fiber types and their roles. Right, Group A fibers are the myelinated, large-diameter, high-velocity ones. You have to commit this list to memory. First, you have A alpha fibers. They're the largest, fastest motor and proprioception. Then A beta fibers, a bit slower for pressure and proprioception.
And the last two.
A gamma fibers handle motor function for muscle spindles. And then A delta fibers. These are crucial. They carry that fast, sharp pain along with touch and temperature. They are your immediate alert system.
Excellent. So that's the A team. If we slow it down and shrink the diameter, we get to B and C groups. What's the key difference there?
Group B fibers are still myelinated, but they're smaller and slower. You find them specifically in preganglionic autonomic nerves. Then you have Group C fibers. These are the slowest, smallest, and critically unmyelinated. They handle a whole array of diffuse sensations, postganglionic autonomic nerves, and in the dorsal root, they carry that deep, persistent ache, slow temperature, light touch, pressure, and itch.
So A delta is the sharp sting, and C is that long, dull, throbbing ache.
Exactly. Let's pivot to assessment. No matter how the nerve was injured, the Medical Research Council, or MRC, grading system is the language we all use. Can you give us the definitive summary for both motor and sensory and really emphasize those tricky middle grades?
This scale is non-negotiable for the boards. Let's run M0 to M5. M0 is no contraction. M1 is just a flicker of contraction. M2 is movement with gravity eliminated. This is where you have the patient move the limb horizontally, parallel to the floor.
Okay, and M3 is the next big step up.
Right. M3 is movement against gravity. So they can lift the limb, but they can't take any external resistance. M4 is movement against resistance, but with reduced strength, and M5 is normal function. That M2 versus M3 difference is so key for showing progression in a clinical setting.
And the sensory scale, S0 to S4, is where the fine-tuning really comes in, especially with those hypersensitivity indicators.
That's right. S0 is no sensation at all. S1 is the return of deep pain sensation only. It's usually the first sign of protective sensation coming back. With S1 plus there, we start to see superficial pain return. S2 is pain and some light touch.
And S3 is where it gets a little more subtle.
It is. S3 is the recovery of S2 function, but, and this is important, without the overresponse. If you see an overresponse hypersensitivity or dysesthesia, the patient is S2 plus say. That's a huge sign of nerve irritation during regeneration. Then the high-functioning grade is S3 plus ALE, which means imperfect two-point discrimination. And finally, S4 is normal sensation, including normal two-point discrimination. You have to know those plus signs. They tell you about the quality of recovery. Now let's talk trauma. When a nerve is transected, what are the two distinct degenerative processes, and what are those crucial structures that form distally, the ones that act as our regenerative blueprint?
Okay, so degeneration happens in both directions, but the major process is distal. Proximally, it only degenerates up to the nearest node of Ranvier. Dentally, though, we see Wallerian degeneration. That involves the rapid breakdown of the axon and myelin by macrophages and Schwann cells. But what's left behind is the framework.
And that framework is the lifeline. The remaining basement membranes form these empty endoneurial tubes, the bands of Bugner. They are essential. Think of them as a pre-built conduit, the biological scaffolding that guides new axonal sprouts toward their original target. If those bands of Bugner are preserved, regeneration is just so much more successful.
Speaking of guidance, we often hear two terms used almost interchangeably, but they're fundamentally different. Neurotropism and neurotrophism. Let's clarify those. And the source of the growth factors, too.
Right. If Wallerian degeneration provides the path, these two processes make sure the axons follow it and thrive. Neurotropism is the directional pull. It's the selective growth towards the end organs. It's the roadmap that makes sure motor fibers go to muscle and sensory fibers go to skin. And that's mediated by nerve growth factors and cell-cell interactions.
So if neurotropism is the roadmap, neurotrophism is the fuel.
Exactly. Neurotrophism is non-selective, non-directional growth. These are just the supporting factors that keep the cells alive. And the high-yield fact here is that almost all neurotrophic factors, NGF, CNTF, IGF, fibronectin, laminin, they're all produced by the Schwann cells. The Schwann cell basically turns into a regenerative engine after an injury. Now, for what might be the highest yield concept in nerve injury, the classification systems. You must master the relationship between Seddon and Sunderland. Compare the two for us and tell us why Sunderland's 5-tiered system is better for prognosis.
Seddon is the classic 3-tiered system: neuropraxia, axonotmesis, and neuromesis. It's simple but a bit crude. Sunderland expanded on this because he saw that recovery potential depended on which of those connective tissue layers survived. So Sunderland first degree is just a conduction block. The axon is fine, the endoneurium is fine, the nerve is just dunning. That corresponds to Seddon's neuropraxia. Recovery is complete.
Okay, so that's the simple one. What about the next levels?
Sunderland's second degree is a true axonal injury with Wallerian degeneration, but the critical endoneurium tube is intact. Recovery should be very good, because those bands of Bugner are there to guide the axon perfectly. This falls under Seddon's very broad category of axonotmesis.
Right. Axonotmesis covers a lot of ground in Seddon's system.
It does, because Sunderland third degree is also axonotmesis. Here, the axon and endoneurium are divided, but the perineurium and epineurium are intact. Recovery is reasonable, but it can be incomplete because the axon has lost its specific tube. It can get confused, crosswire.
And the 4th degree.
Sunderland 4th degree.
Yeah.
Complete division of everything internal, but the outer epineurium is preserved. This often becomes a disorganized mess of scar tissue, a neuroma in continuity. You'll get very limited recovery without surgery. This is also technically axonotmesis. Finally, Sunderland 5th degree is a complete transection of the entire nerve trunk. This is Seddon's neuromesis. You have to operate for any chance of recovery.
And just to be complete, remember McKinnon's 6th degree injury. That's the crush injury with a mixed pattern of damage. You might have 5th degree damage in the center, but 3rd degree on the outside.
Okay, moving into the OR. Let's say we have a clean, sharp transection, the best case scenario. What's the preferred repair method, and what's the cardinal non-negotiable principle?
Primary repair by direct approximation is always the first choice. You trim the nerve ends back to healthy, bleeding tissue, and then you perform an epineurial repair under magnification with fine sutures, like a 90. What's interesting is that studies haven't really shown a clear clinical superiority of fascicular repair over a careful epineurial repair in most cases.
But the absolute non-negotiable rule that decides if you can even sew it directly is tension.
Correct. Repairs must not be under undue tension. The practical line in the sand is this. You should only do a primary repair if a single 90 suture is strong enough to gently bring the nerve ends together. If you need more force than that, you have to mobilize the nerve or, you need a graft.
And if direct approximation is possible, especially in a big nerve like the median or ulnar, how does a surgeon accurately match up the fascicles? You have to make sure motor meets motor and sensory meets sensory.
Yes, preventing rotational mismatch is a functional catastrophe. We have 4 aids. First is just simple matching of anatomical structures. You look at the size, shape, and orientation of the fascicles, or even the pattern of the surface blood vessel.
And number 2 is time sensitive.
Right, electrical stimulation. You can stimulate the distal stump, and the motor fascicles will still respond for up to 72 hours after division.
Okay, what else?
Third, if the patient is awake, you can use conscious stimulation of the proximal stump. Stimulating sensory fibers gives a sharp pain, motor fibers give a dull ache. And finally, and this is crucial, knowledge of internal nerve topography. You just have to know, for example, that in the ulnar nerve at the wrist, the motor fascicles usually lie centrally between the volar sensory branches and the dorsal sensory ones.
So if that crucial tension test fails, we move right to bridging the gap. When is a nerve graft mandatory? And what is our current gold standard?
It's mandatory if you can't get a tension-free primary repair. You can try to gain some length by mobilizing, like transposing the ulnar nerve at the elbow, but if a gap remains, the gold standard is still the autologous nerve graft. You're giving the patient their own tissue, complete with viable Schwann cells and endoneurial tubes. It's the best chance. But beyond the autograft, we do have alternatives. What are the other options, and what's the crucial consideration when you use allografts?
Well, people have tried fresh nerve, segments of vein, freeze-thawed muscle. When we use allograft nerve from another person, systemic immunosuppression is required to prevent rejection of those foreign Schwann cells. And you have to maintain that until you have clinical evidence, usually a Tinel sign, that confirms regeneration has successfully crossed the graft.
And the specific drug used for immunosuppression here is particularly interesting because it has a dual benefit.
That would be tacrolimus. It's the preferred immunosuppressant because it also has proven neuroregenerative properties. So it gives us an advantage beyond just stopping rejection. We're also seeing more use of synthetics like absorbable nerve tubes made of polyglycolic acid, especially for very small gaps. Let's quickly detail the 4 common autologous graft sources. You need to know their lengths and landmarks for planning your harvest.
Okay. Number 1 is the sural nerve. It's the workhorse. It runs behind the lateral malleolus. It's the longest source, giving you up to 30 to 40 centimeters in an adult, so it's ideal for big defects where you might need multiple cables.
And for smaller defects.
The lateral antebrachial cutaneous nerve, or LABCN, it's next to the cephalic vein along the brachioradialis. It's shorter, you only get about 8 centimeters, but the sensory loss is minimal due to overlap. It's a great choice for smaller gaps.
Okay, 2 more.
The medial antebrachial cutaneous nerve, or MABCN, you find that in the groove between the triceps and biceps, right next to the basilic vein, gets you a good length, up to 20 centimeters. And finally, the terminal branch of the posterior interosseous nerve, the pineen, it's in the base of the 4th extensor compartment of the wrist. This is really only useful for bridging very small defects in small nerves, like digital nerves.
In wrapping up the surgical technique, let's just recap the fundamental principles of grafting.
Sure. You always trim the nerve ends back to healthy tissue. Grafts must be reversed, so that's crucial. Turn them 180 degrees to guide the regenerating axons distally. You have to place the graft on a healthy vascularized bed. And for large defects, you stagger the cables to prevent a single scar band from forming. And of course, you have to restore proper sensory and motor alignment.
That was a really comprehensive, targeted review. We covered the nerve's architecture, the high-yield classifications, with Sunderland being the key prognostic system, and the rules for tension-free repair and graft selection. Mastering these specifics is just absolutely essential for your exam.
Absolutely. And when you're thinking about these concepts, think back to that fact about tacrolimus, the immunosuppressant for allografts that also has neuroregenerative properties. It raises an important question for the future. If we can localize the delivery of such powerful neurotrophic factors, what role might targeted drug delivery play in optimizing even standard primary nerve repairs? Could we boost growth rates beyond what Schwann cells alone can provide? That's really where the cutting edge of nerve repair is headed.